and Dr. Jerry Tolbert.
Hello, everybody, and welcome to the first episode of The Medical Show. Don't call it TMS. We've been here for years, or how's that rap go? I don't know how that goes. Anyway, I'm Scott Johnson, and I'm one half of this business. The other half is Dr. Jerry Tolbert. Welcome, Dr. Jerry. How are you?
I'm doing well.
Good. Do they call you Dr. Jerry at the office or Dr. Tolbert at the office? What do you require there?
I don't require anything. They can call me whatever they want. I answer to just about everything. I got used to being called Dr. G because my dad is Dr. Jerry Tolbert with a J. So that's what most people call me is Dr. G.
Yeah.
But I go by pretty much anything.
For a second, I was going to say, if they walked in and went, "Yo, G," is that offensive? It's fine? You don't care? Whatever.
I don't care at all. As long as people are talking to me and not afraid of me, I'm good.
That's good to know. That's how the show's going to be. Don't be afraid of Dr. G. He's sitting over there just chilling. But do know it's G, not J. Don't mess that part up. He'll cut your fingers off for that. Just kidding. Who would he? Why? What kind of doctor would cut off anyone's fingers? Unless it was an amputation and it was required.
I was going to say a vascular surgeon does sometimes.
Sure.
And orthopedics do occasionally, but
I'm going to ask you a question about that before we even get into it.
Okay.
When somebody has to have a limb removed or an appendage, a digit, a finger, a toe, whatever, I notice these days, there must have been something gnarly that went down in the past, because I notice these days the doctors go out of their way multiple times, and I don't just mean 2-3 times, sometimes 5, 6, 7 times, to ask the patient if this is the right limb or knee or leg or whatever, make sure the mark, like the X in the blue marker or whatever, is on the right leg or left leg, depending on, the correct leg is what I'm trying to say. They did this with my eyes when I had eye stuff. And it just seemed like it was overkill, but also I knew in my heart of hearts, so this is good. They're not going to take the wrong eye. So I assume that this is like a huge thing you guys have to adhere to. Don't take the wrong eye, the wrong ear. Don't poke the wrong hole, whatever it is.
You've pretty much said it all. The reason that there is a red flag rule, meaning that you have to do all of those things, is because wrong side surgery, so paired appendages, if you take the wrong one, that is a massive, massive problem. That is not something that we can put back.
Yeah.
So we have to be very, very careful not to do the wrong thing, and it happens more often than people realize. And
I assume it's happened before, and that's why the caution, right?
It was happening hundreds of times a year, and that's why they are very, very, very careful about making sure things are labeled correctly. You have to have appropriate discussions, and all of the people in the room have to agree, and the surgeon will oftentimes sign the limb that they're getting ready to amputate.
Oh, my.
Because they want to make sure that there are no wrong side amputations, because you can't go back.
Yeah, that's true. Yeah, I'm glad. As one potential patient in the world, I would say I think that's really good that you guys are marking the correct limb. I don't want the wrong one gone. That would be bad, because then you end up taking the other one, right?
Right, because then you lose both.
Yeah, you got one that's all gangrenous or whatever I don't know what it would be today. I'm just going to make
That's
up a lot. Get used to me making.
Absolutely.
Is it good? Okay. Get used to me saying words that may or may not be correct, and then Jerry correcting me. But I'm glad gangrenous was right. But if I've got a left leg that's messed up and I'm out, like I'm already put out, and they have forgotten which leg they're doing, I'm going to wake up with the wrong leg missing, my good leg missing, and they're still going to have to go do the other one if they didn't just do it all at once. And you can't just say, hey, I'm doctor, put it back, and I can put that leg right back. They can't do that. That's not the world we live in. So
no, we can transplant a lot of stuff, but once we remove a limb, it's pretty hard to put it back on.
Oh, I have so many questions about transplants and the supposed underground organ stuff. We'll get there eventually. See, that's my problem. Is I don't want to spill all the popcorn at once in this lobby. We're going to do it over time, everybody. And we may as well introduce how this is going to work. So if you're used to listening to Frog Pants shows and they're used to my dumb voice, and there's not a lot I have to say to explain who I am to you, but if you don't know, I'm Scott Johnson. I run the Frog Pants Network, and it runs the gamut of everything from a daily morning show all the way to like video game related shows and lots of weird stuff in between, and none of it medically sound shows, okay?
Hey, I've contributed a few times. My stuff's medically sound.
That's true. He'll call into the to TMS, the other TMS show, the morning stream, and he'll correct us on all sorts of stuff or give us good advice. And that's about the only time I can guarantee you quality medical advice is being dispensed on that show. But I wouldn't, count on the rest of the network to give you too much of that. Maybe a little mental health stuff from my sister on Thursdays. But beyond that,
Dan, don't forget Dan. Dan does a great job with all of the medicines and the pharmaceuticals.
That's true. If you want to know what's going on with pills, he's your man. He's your pusher. I'm making it sound like he's your dealer, and I don't mean to be doing that, Dan, if you're listening. But anyway, so we thought this would be a great idea to have a show about the medical world, and not just does this look infected to you, but things like, what does it mean when insurance does this? Or what does it mean when Congress passes something that affects, overall healthcare in the country, or things that happen internationally, or breakthroughs that happen? What do they mean to regular Joe going in for his checkup every 6 months? And kind of everything in between. Like we're not going to put any real specific walls around this. We're going to talk about a lot of modern healthcare and how it affects you. We'll even talk about maybe some old ideas that some people think are great again, and we'll talk about whether those are actually good or not. That was not a political reference, by the way, the great again part. I just want to clear that up. It's going to sound like it was. I swear it wasn't. That was just talk. That's just words. That's English. All right, everybody? Anyway, but I think to do that, we need to know more about Dr. Jerry. So you've been at this for 20 years. This isn't your first time to this rodeo. You've been a doctor for a long time. Tell people a little bit about who you are and what you do.
Well, I am a board-certified family physician. I trained in medical school. I went to the University of Kentucky and started there in 2003. And while I was there, I did a dual degree, MD, MPH, which is a master's in public health as well as the MD degree. I got about 37 out of my 39 hours for the MPH in biostatistics and epidemiology, and decided that I didn't need the letters as much as I needed the extra time. So I know how to do biostatistics and understand epidemiology, but I don't have those letters after my name. It's just the MD.
Gotcha.
I went to residency in South Carolina in a little town called Greenwood, where you may remember that is very near to a place that Brian Dunaway lives.
Fellow Frog Panther Brian Dunaway. Yeah. I don't know if you ever felt his presence, because he was a bit of a medical mess back then, but that's not true. I made that up. That's all made up.
We never crossed paths the entire time I was there.
Weird. It's almost like there are a lot of people in these areas, and it would be really hard.
People.
Sure.
The hospital was a very large hospital. It was what's called a sort of a tertiary center. We got a lot of outlying hospitals that may have only 20 or 50 beds, and they would send their patients to us that needed higher level care. So as a resident, I got to do everything. We got to take care of medical patients across the floors in the ICUs. We delivered babies, full spectrum family medicine training, and it was a great opportunity to do that. And I did 3 years there, and then came out of there with my family medicine residency training complete. So I had 7 total years there, and between med school and residency. And then I came out and went into practice with my dad almost immediately. It was about a 6-month lag time just to get everything set up. But we set up what's called a direct primary care practice, which we'll get to eventually as we talk about all these things. And it was just the two of us in practice together. We did all of the stuff that you would normally think of with a doctor's office, but we did it ourselves. So we would draw blood. We would do the vital signs for the patient. We would do the visit with the patient. We took phone calls. We did house calls. We did hospital care. So we did everything at that point.
House calls. That's interesting. Babies. That's interesting, because I thought that was a long gone practice. Just time has passed and that's all history. That's still a thing you can do in small towns, I guess.
Well, at the time, we were in a medium-sized town, but we did it because it was a thing that was so difficult to get. And we had a lot of patients that came to see us specifically because we still did that. So it was sort of one of the, not necessarily a gimmick, but one of the services that we offered that was bringing people back into the fold that may not have been seeing a doctor on a regular basis. So It made it easier for patients that were not able to travel easily or didn't have good sources of solid transport to be able to get to the doctor or the doctor to them.
Between medical school and residency, before coming back and getting in with your dad with the practice, did those, which of those two things is more, it sounds like to me like your residency was a very huge learning experience. Like you really got the brunt of what you hope a residency would give you, all of that experience in such a broad stretch of experience. But of those two, what's the hard one? People always think medical school is long and arduous and all of that, but it strikes me that residency, which is a hands-on, you're there, patients are in your hands, the pressure's on, that seems like that would be the harder of the two.
It was hard in different ways. the amount of information that you have to jam inside your head in medical school is huge. We learned 15,000 separate terms during the anatomy class in our first year of medical school. So it was like learning an entirely new language in about 15 weeks. And so that was a very, very hard thing. That weeds out the people that aren't committed to putting in the work to do it. There are some people that are naturally gifted with memory and can do other things, but if you can't handle that much studying, it's not going to go well because there's that much medical information being released to the public and just medical science proceeding forward over the course of time. So we don't have the option of not being able to pay attention. If we don't, then we're going to fall behind and we're not going to be able to help people adequately. So that medical school teaches you that. It teaches you where to find the information. It teaches you the language of how to talk about the information. And we're going to get into that in a future episode, the importance of that terminology and that information. But residency was a whole different ballgame because, like you said, you are actually kind of starting to be in charge. You're learning how to take what you learned in the classroom and turn it into taking care of actual people. And that was a different way of looking at things. You are also, in a lot of residency programs, you're going to have things like call, meaning that you are on for multiple hours of the day. That's shifted a lot since I was a resident. When I was a resident, they had just put in orders that you couldn't work more than 80 hours in a week. To let that sink in, you had to work fewer than 80 hours a week.
Wow.
And that was actually a huge controversial thing because a lot of surgical residents before that point, and even residency programs that were much smaller, they were having people put in hours that were well above 80 hours per week. Jeez. For context, there are only 168 hours in a week.
Yeah, so thank you. Yeah, we have a certain. There are only so many hours in the week. That's pretty close to that ceiling. I'm a little surprised.
Right.
Wow.
Well, and 80 was controversial, and it's even lower now, which was even more controversial when they made the change. But
is it controversial in the sense that the doctors don't think that? Is it one of those things like, well, back in my day, I had to do this? Is that the gist of that?
For most of the folks that thought it was a bad idea, yeah, absolutely. There was some concern and valid concern about how much actual learning happens while you're on call. When I was a resident, you were the only person in the building at times. There were people that were there for your backup. You had one or two other people with you. But as a high-level resident, as a third-year resident, we were the ones that were kind of making a lot of the calls at a split second. And then we had to make sure that we were, ready and able to do that at all hours of the day. So you don't want to be sleep-deprived and make bad decisions. So that's absolutely a big part of making sure that people have time to recuperate and don't get burnt out. Yeah. But the problem is you miss out to some degree. And this is not a blanket statement, but you do miss out on some of the good learning that happens when you're the only one that's there. And things overnight, that's when the weird stuff happens. I mean, everybody knows that. That's when you have to go to the ER because you can't go to the doctor's office. So it is an interesting balance that has to be struck. That doesn't mean that residents training now are trained any less well, as long as they are able to get the breadth and depth of learning that they need. So
I remember my dad always said, and this is not uncommon, a lot of parents said this to their kids, but they would say nothing good happens after midnight. And my experience was all the bad medical stuff always happened after midnight, whether it was your kid waking up screaming about some pain they didn't have before. If someone's appendicitis is going to kick in, it's going to be at like 2 a.m. It felt like every time. For sure, that's a thing. And I guess they do. I could see how the medical industry, the medical world would want you as honed as possible to handle those high stress situations, even when you're the most tired. Maybe this is the most, you can tell me this if I'm wrong or not, but maybe this is the most realistic thing about medical dramas on TV. It's not the tech or the processes or the way hospitals work or any of that. It's that some guy has to sleep in a locker room for get 14 minutes of sleep because they're shorthanded and there's a big group coming in and they got to have people on staff. And like that stuff seems like that might be more realistic based on what you said about hours. That's crazy.
It is incredibly accurate. Although I always joke that I am a bad person to ask that question because I am what is called a white cloud in medicine. And so there are what we call white clouds and dark clouds or black clouds. Black clouds are people who, when they come on service, the hospital is going to set on fire. And when white clouds come on service, the hospital might as well be shut down. Like there's nobody coming in.
Yeah.
And when I was a resident, I did something that in my residency program, no other resident had ever done. I had 2 what we call no hitters. Yes, we use baseball terminology occasionally.
Sure.
I had 2 nights where I got no admissions at all.
Wow.
And that is incredibly rare when you are on call because you're the only doctors for the program I was at. We were the only doctors in the building.
Wow. Everybody's being real safe on those nights. So,
or they're afraid of me, I guess. I don't know.
Could be, but like if so I'm just trying to understand the difference between the white and the dark cloud. Dark cloud or gray cloud, black cloud. That's about there's a storm coming versus you're like clear, sunny guy where nothing's going on and it's just beautiful and here we go. Right? That's
so one of my upper level residents was a very black cloud, and she is actually somebody that I work with now. And she, when she would be on call, would she wasn't actually inviting people in, but it might as well have been like she opened the doors, threw them open, and said, "Everybody get in here now."
Yeah.
We would admit 10, 12, 15 patients a night in some cases with her. And that is a lot. Most of our services never really got much more than 12 to 15 patients on a service. So the whole group that we were taking care of for the days that we were on.
Do you ever have anything that you would consider just like massive, like, whoa, that was the night the train derailed and everybody came flooding in? That must have been wild for your first or second time seeing that.
We've had a few of those where I had one night where I did do 12 admissions. That was kind of my max, but there were several residents in our program that had done 15 to 18, and that's not something we want to happen on a regular basis. So there were programs put in place after that started to happen that we could have some like a steam release valve, basically, so we didn't overload.
So they want you to be, but the bottom line sounds like they want you to be sharp in hard situations, whether there's exhaustion involved, whatever it is, that you can find the way to do it. But there's also limits to that. If it's 18 or more people, at some point you can't manage that. Right. And mistakes are going to get made. And so that wasn't an interesting balance. And I assume that target changes, like recommendations from research or something may come out and say, hey, it turns out they need to be working less hours, and which is probably responsible for some of these changes, right?
Absolutely. That's exactly why the changes occurred, because they were seeing that the level of errors or that the level of burnout or the level of problems that occurred went up with larger numbers of patients and longer hours in the office or longer hours in the building.
Sure.
We were capped at 30 hours contiguous. We couldn't go past 30 hours in a row. And that included our call. So when I would be on call, it was from basically dinner time one night until lunchtime the next day that I was officially on call.
Yeah.
And we would be taking care of patients throughout the rest of the day. But the person that was on call would go home and go to sleep for that extra 8 hours. I usually slept straight through and then woke up the next morning and had a clear day. And then we were back on call the next day. It was every 3 days when I was a resident.
Dang. That's a lot.
Yep.
Yeah.
And that was 10 out of 12 months that year.
Well, that to me, that's proof enough why just enough people become doctors, right? Yeah. Not everybody can or will or is able to because of things like that. That is a commitment, especially early on in training and school and early residency and all of that, where it's just, that's going to be your life for however long. And at that time of your life, that seems like a long time. Like you mentioned 7 years of residency, right? Something like that.
Well, so 4 years of med school, 3 years of residency.
Oh, that's right. So to combine. So those two, that's 7 years. When you were the age you were, at that age, that would have seemed like an eternity. 7 years is looking down the barrel of like the long, you're like, am I going to be dead by 7 years? Like it seems insane. Nowadays, that doesn't seem like anything. 7 years is like so quick, which just comes with age, I think. But was there ever a time where you were just like, oh man, I don't know. Like you're so upbeat about all this. I'm just curious if you ever had a moment where you're like, I don't know. And then, a glowing stethoscope showed up and said, you can do it, So I don't hide the fact, but I don't talk about it as much now as I did when it first happened. But I actually had to repeat my first year of medical school. I never got a low enough grade to fail any class. I knew the material front to back, but when I was going through medical school, the first year of medical school, the first time, I did, and frequent Frog Pants listeners will understand this, I was a pretty big video gamer at the time and spent a lot of time playing games with one of my other friends who was in med school as well. Sure. And we ended up goofing off a lot more than we probably should have, myself specifically. Yeah. And so on test days, I did okay. My grades were fine. I never failed anything. But because of the way that the system was set up at the University of Kentucky,
if you didn't meet a certain GPA threshold, you couldn't advance to the next year. If somebody failed a class, like one single class, they could take a test for that class and test into the next level if they understood the material. At other med schools, they were pass-fail. So if you passed the class, you passed. The old joke, C's get degrees, is very true in a lot of cases. And so, the grading systems are there for a reason. And this is not me saying that they did me dirty or anything.
Right.
It's more, I didn't put in the work for the testing part of things. I learned the material, but because I had never made it through the GPA threshold, I ended up having to repeat the first year. So if you ask me questions about biostatistics or biochemistry or neuroanatomy or physiology or, anatomy, any of the things that we had during that first year, histology, the cellular stuff that we do with microscopes, I know it cold because I did it twice.
Did it 2 times.
Exactly. And I would not wish that on anyone because it is a lot. But at the same time, it was way easier the second time. So I definitely brought my GPA back up. But I did have to repeat that first year. And so it was a very eye-opening moment for me to say, are you really geared to do this? Can you do this?
Right.
And the answer was, yeah, I'm going to do it no matter what. I'm going to go back. And the sad part, and this, my wife will love me telling this story. I found out less than a week before our wedding that I was going to have to repeat that year. So I literally had to come to terms with the stress of that realization in less than a week. Because if I had ruined our wedding, my wife would have ruined me.
Yeah,
so
you would have.
No choice.
Yeah, you'd be licking those wounds now. You know
exactly.
what I mean? Well,
she would have beat me up
for sure. So you might say to yourself at home, boy, that sounds a lot like me. Everyone has times like this in their life. I'm just curious is there one video game we can blame though? Is there one title?
Star Wars Galaxies.
Was it Galaxies? Oh,
it was Galaxies.
I was going to guess because I know you're a big MMO guy and I know you like that stuff. And I thought, well, what's going on in 03? And that was a big piece of business. If you were willing to put the time in, that game had some depth. And I can't imagine doing that while trying to pass medical school. That'd be insane.
So I became a Jedi, just to put it in perspective.
Oh, no, dude. People don't understand. You're listening to this. Maybe some of you tuned into this I'm looking for a good medical show. Let me tell you something. That is not a small thing to say. Becoming a Jedi in that game was nearly impossible. You did it? You pulled it off?
I did. So it was sort of midway through people had figured it out a little bit, so we knew kind of what the pathway was. Yeah. And there was enough information out there if you knew where to look that you could, if you put in the time, you could make it work. And I did. And so I had a Wookiee Jedi. So it was one of my crowning achievements as a gamer. And it cost me another year of med school, which is, again, that to put it in perspective, that also was a year that, as far as, and we haven't even started talking about the financial impact of going to medical school, but we lived on loans. So as medical students, you were not allowed to work. We had to sign a contract that said we would not work.
Yeah.
So I literally lived on loans from the bank that covered my tuition and my books. And I had a computer loan, which is why I played Galaxies. But also we had all of our food and our housing and everything had to come from that. And so when I repeated that year, we didn't get the same level of loans because it was a repeat year. So for the first year we were married, my wife and I were living on a shoestring, which taught me a lot. I mean, I grew up not in I was middle class, firmly in the middle class, but I grew up in the middle of the country. And so I was used to living on not a lot, but it was a real lesson in how to make ends meet and also still get work done and be studying as hard as I possibly could. They wanted us to not have that distraction.
That's wild. I had no idea. I didn't know you had to sign a thing that says I will not have any side job or anything while I'm doing this. Which makes sense, right? You have to have full focus is the idea.
Exactly. Yeah. They don't want you to come in and halfway do it and then take a spot that could be going to somebody who's going to actually complete the program.
Gotcha. Well, this is good background on how part of that works. Well, like you say, future episodes will definitely be touching on more of that because I think it has relevance to what is happening in the medical world today. But you might ask yourself, listeners, you may say to yourselves, why are you doing this show? And I would give you this simple answer. We think this is going to help people. The goal here is not some big gnarly Patreon. We don't have one. We're not doing any way of like big fundraising for this or any kind of like, hey, this is another little moneymaker side deal. You could say we signed a contract, a mental one anyway, that we are not going to have other jobs for this podcast other than it to be its main job, which is to talk about the medical world and do it honestly and straightforwardly and answer your questions and really dig into the issues that matter to people. And also, it bears mentioning that the medical world is freaking confusing. Most people don't even know what their insurance means. They don't know what's covered. They hope they never have to use it. They find out sometimes in the hardest way possible that stuff isn't covered. Sometimes they're told they're covered and then they're not. We're not going to be hey, let's just crap on the insurance business show, but some of those things are going to be a part of this because, especially in this country, it's a for-profit business. It works in a way that has a lot of middlemen. It's not a government service the way you might find in the UK or Canada or something like that. And so the rules are different and how you navigate it is different. And we hope this show will be good at making sense of that part of it, which will also help you make sense of your own personal health, your own personal decisions, good practices, bad practices, debunking some stuff, plenty of that going around. Like we're about to get asbestos back in our lives, apparently, I heard yesterday. We're lifting the ban on that. Makes no sense to me. But, we living in a time where you're not quite sure what's up and what's down, and there's no shortage of voices telling you what's going on. We're going to try to disseminate that and, try to make sense of it. That's the goal. That's the show. All right? And we hope you guys enjoy it. Why do you suppose modern healthcare is so confusing for some people? Like, do you think it's just that we've inserted so much into a system that should just be, I go, he checks me, says I'm okay, I go home. Or I go, they say, that lump looks weird, let's get it scanned, we've treated it, you're fine. Whatever the answer is when you go to the doctor, that should be the transaction. That should be the simple transaction in our minds. Like 1800s, Doc Johnson comes to the house, checks me out, gives me the clean bill of health, says I no longer have the rheumatiz or whatever it is they've got going then, and then he leaves. And that's the end of the transaction. It's way more complicated than that today. So I guess that's the simple question with a hard answer. Why is modern healthcare so confusing?
And the answer is it's very complex. So to put it in perspective, you mentioned the old family doc that came, and actually family medicine didn't start until the 1960s, so he would have just been a general practitioner. Probably wouldn't have had a residency, would have had 4 years of medical school, and came out and hung up a shingle and started a practice and started treating people. And when they started their practices back in the 1800s or so, the first real physicians kind of rolling off the line from the medical schools that were starting in the United States, they had roughly 400 compounds that they were using, just kind of, not all of them were being used commonly, but there were about 400 things in what's called the pharmacopoeia.
Oh my gosh, really?
Back me up on this. But yeah, so there were 400 things that they had to know how to use. That's it. Think about, if you think about it as, okay, there are 400 compounds, we need to know what they're for and what their name is. If it's only those two pieces of information, that's 800 pieces of information. We can do that in our sleep. We can memorize 50 states and 50 capitals and things like that. So there are lists that are manageable lists, even at 400. As of this year, there are more than 20,000 compounds that we use for medicines between over-the-counter and prescription medications.
That's a lot more than 400.
And now you're talking about 40,000 pieces of information.
Wow.
Right? Because it's and that's just the simplified version of it, what it's for and what it does. So in terms of our ability to process that information and safely connect you to the parts of that information that are going to help you is incredibly complex. And we want to make sure that we're not doing that wrong. Just like we talked about with writing the name on the limb, we have to do that with making sure that we're not giving you the wrong medication. So we have to see if you have allergies to those medicines. We have to make sure that we are not prescribing something that your insurance, and we talked about insurance, that your insurance isn't going to cover. If it's not on your formulary, the drugs that your insurance has chosen to cover for whatever reason, because of cost or other deals that they've made, then that medicine may not be the best choice for you because it's going to cost you an arm and a leg, no pun intended, in order to get that medicine and be able to take it safely and get the benefit from it. So figuring out what's going on, understanding the complexities of disease, which is much more, we have much more understanding of how things work. We're still very, very in our infancy in terms of what we understand, but we understand way more than we did in the 1800s. But you start stacking those things on top of each other, and even without things like insurance, it is a very complex system. Then you start talking about payment, and you start talking about the ability to pay into insurance and then have that cover. That is only about 100-year-old system. And so it has, over that course of that time, become ingrained in our society. Everybody's got to have insurance or they can't get health care in the United States.
Right.
And that has added a whole other layer of complexity on top of what's scientific complexity.
Sure. And the age-old idea of throwing into a pot, you're in an old village, the chieftain says, hey, we're all going to just put our pineapples in one pit right here. I don't know what culture I'm talking about, but they exist somewhere. So we're all throwing our pineapples into this pit. Exactly. We're in Hawaii for some reason. We're all throwing our pineapples in, and we say, all right, well, the idea here is that not everybody needs pineapples all the time. But when you do need it, there will be plenty of pineapple because everybody's pitching in on the pineapples. And one of you may be lucky to go your whole life without the need of a pineapple. But eventually, Larry up the road's going to need a pineapple. And thank goodness he's been dutifully putting his pineapple in once a month because now he can get to the pineapple because he's going to be in need. It's a simple system on that level, and it makes sense to me in my dumb head. Why have we made that so muddy now? In other words, if you have an insurance-based system, if everybody is paying in, why is it sometimes so hard for you guys as the medical office or us as the patients? Why are we always having to fight over it? Isn't it just as simple as, well, the guy came in, we had to prescribe boozeloxetine, whatever, sounds like beer, a drink, but we had to give him this drug. It's perfectly appropriate for his condition, and 100% should be covered. Plus, the guy has been putting into the pineapple hole for years.
Yep.
But then the insurance company said, nah, we don't think so. We don't think that guy, especially the pre-existing condition times. It was definitely a time where you would get turned down for that stuff. Help me make sense of that, if you can. And neither of us, I should say, you've had way more experience with insurance companies than I have, but I don't think either of us really truly know everything there is to know about the insurance world. But from the best you can tell, well, why does that part have to be so complicated if they are indeed paying into the system?
So the idea that you're putting money into a pot that is then just going to be taken right back out of is where that analogy kind of breaks down. Our current system is not set up that way. It is pooled risk. You're not wrong. So we are putting money in the hopes that we never have to use it. But if we ever do need to use it, we want to be able to draw back on that.
Right.
The cost of things that come out of that pot, depending on the people in your circle that are putting into that pot, can be $150 a year for some people if they're really healthy. It can also be $40,000 over the course of a week if somebody has to have a major surgery or a transplant. You're talking hundreds of thousands of dollars at that point.
Right.
You could empty out that pot with one patient in 1 week.
Right.
So there are other methods of maintaining that money that have to be met. There are government subsidies that come in the 1940s and 1930s, 40s, 50s, 60s, and up to today. We have Medicare and Medicaid rules that are constantly in flux, that are the sort of public option for insurance in the United States. That complexity grows every time we add another layer of people in between. And we now have something called pharmacy benefits managers, which help the insurance companies negotiate prices between the drug companies and the insurance. How are they going to pay for it? How much is it going to cost? Can I get a discount because I'm buying in bulk? That process adds another layer of complexity, which adds another layer of cost, which adds a whole other layer of walls that have to be put up to maintain those discounts and make sure that money stays solvent and that the companies continue to be able to pay for what is needed. That also, and again, this is not getting political, but they also have to pay salaries for all of the people that are working for those groups. Sure. And sometimes those salaries are way more than people would expect them to be or want them to be. And I'm not going to go on record here as saying that I agree with how the salaries are paid out. I don't. And I think that there is a certain middle ground that would probably be more appropriate. However, that is what it is, and that's nothing that we have a lot of control over directly.
Sure.
You mentioned pre-existing conditions, and one of the things that happened when we got, you can call it Obamacare, you can call it the ACA, but the provisions of that act that allowed an expansion of services for people that already were sick, that hadn't already gotten insurance. So they're putting things into the pot after you already know that they may have to have a leg chopped off, right? They were able to buy into those systems or to get access to those systems that they couldn't before. the upside to that is that it allowed so many more people to access healthcare. And the sad state of things in our country, just even 15, 20 years ago, was that the average person who was making an average wage couldn't afford to pay into that pot at a level that would actually allow them to pull back out of it if something really catastrophic happened.
Right. They need major surgery, they get cancer, they have any of those things that are kind of in the echelon of major out of pocket, or even an MRI scan these days, like whatever.
Absolutely. Even back then, especially back then, MRI was a relatively new technology in the 80s. Yeah. That was not something that you could just walk to the corner store and get one. These days, there are MRI scanners pretty much everywhere that you go, but for some hospitals, they didn't have an MRI scanner until the 1990s.
Well, that adds an interesting little twist to it, too, because now you're talking about some things in this world get more common and more access, and therefore cheaper on the whole, I guess, if you were looking at a giant chart of it all. So it isn't that everything got more expensive. Everything just goes straight up on the chart of insurance costs, although it sure feels like it when you're just a lowly patient.
Absolutely.
But some of this stuff is settling, like it's becoming a standard, or, laparoscopic versus, cutting me wide open for my appendix. I assume is maybe at first it was experimental, more expensive, whatever, but that's got to be a more efficient thing now, right? Like saves money somehow. Like I don't want to argue in favor of these insurance companies at all, or these costs, but I just want I want this show in particular to be very realistic about what is actually going on, and this isn't going to be a place of like, can you believe they're screwing us again? Like I want to look at it more objectively if we can. Yeah. If possible.
Yeah,
it's hard.
And you're not wrong. That is absolutely what's happening. The reason that you don't stay in the hospital after having a knee replacement is that we've done thousands of knee replacements at this point, and we've gotten pretty good at it for the most part.
Sure.
There are still complications. There are still things that we don't always account for, but we are much better at accounting for them than we used to be even 20 years ago.
Sure.
So you don't have to be in the hospital. And in fact, we found better outcomes in some cases with certain surgeries if you're at home, because the hospital is where where sick people go, and you don't want to be around a bunch of sick people when all you're there for is a knee replacement.
Yeah, exactly. Boy, I think that every time I walk in there.
Yeah.
Even to visit people, I'm like, what do y'all got? What's going on in here today?
Imagine working there.
Yeah, dude. I don't know how you guys do it. You guys must have the best. Is this a myth or not that you guys have like the best immune systems because you're just exposed to everything? You think that's true?
Not a myth, but it's not 100% everyone. You do get a low-level exposure to a lot of things. Yeah. And so it's kind of like having kids, especially kids that go to school.
Yeah.
They're going to bring home stuff that you're going to get exposed to. You're going to get exposed to it once. Then you build up a little bit of basic immunity to it. And so the next time you get exposed to it, it's not as intense. Yeah. So yeah, there is truth to that.
Yeah.
But you can't really be immune to diabetes. So that's the hard part.
No, you can't. As a guy who's knocking on that door, I can attest. All right. So the back to pre-existing conditions thing, it feels like, I could be wrong, but for me anyway, it fundamentally changed my own healthcare because I just went, now I can go in and they're not going to say, well, your weird eye thing, sorry, we can't, whatever it is, whatever the thing was. And I'm trying to remember what I had something that they said was a pre-existing condition. Oh, I know what it was. We were all upset because my daughter had kidney surgery for kidney reflux that was when she was really little. And it was before this change. And it was really scary because we knew that, all right, well, now we're hosed. If we change insurance, we're hosed. No one's going to take her. They're all going to go, she had that before, which to me seemed insane because what are you supposed to do the rest of your life? It's like, oh, sorry, you're peeing blood. Well, you had that before, so we can't. Like, it just made no sense to me, and so I have to assume that was a massive change that I hope never goes away.
Yeah, you can assume that, and yes, I hope it never goes away either because it is absolutely pivotal to allowing access to care for people that were sick, that were in the greatest need of care in some cases. So people that had cancer, that lost their job, that lost their employer-sponsored insurance, now have to find another insurance to help pay for their cancer treatment.
And they just turn them down, just not
exactly
do it.
without a pre-existing condition clause in the insurance documentation or the law. they would not have a way to get insurance. They would be losing all coverage for their cancer care.
And that's when humans had to let you know, had to tell you that, which means they had to really put their conscience on the line. If this was today, just robots would tell you.
Absolutely.
This is and AI bullcrap would just say, hey, sorry, you can't cover you. So, man, I'm glad that happened before all this, you know?
Totally agree. It made such a huge impact. And it was really the transition from what I would have called at the time a sick care system to a health care system. We were more focused on treating things once they happened than we were about preventing them from happening to begin with. And a lot of the provisions of the ACA were actually more focused on prevention, which allowed us to get into a system that is much more focused on health rather than on treating sickness.
Well, to that point, is our system more focused on treatment or prevention right now? If you had to just sort of assess the entire thing, what are we better at? I'm going to guess treatment, but you tell me.
The short answer is it depends on who you ask, because if you're talking about things like diabetes, we're really good at both. As far as the healthcare system is concerned.
Right.
As far as culturally, as a group of people, especially in the United States, we're not stellar at the prevention side of it. However, we are, as a healthcare system, we're really, really good at teaching about prevention, and we have the access to the information about prevention. We try to make sure that that's being propagated to the right people at the right times, but that is dependent on your readiness and willingness to hear it, as well as your access to the types of foods and things that are going to be healthy and not have those excessive carbohydrates that you don't need.
Yeah.
So once we get to the point of diabetes, we can start talking about treatment. And one of the biggest treatments, the actually most powerful treatment we have for diabetes, people will say, oh, insulin, right? And since the 1920s, when insulin became readily available, not really readily, but more available.
Sure.
Yeah, that's an amazing drug. It is a wonder drug. If we talk about wonder drugs, it is absolutely one of the best ones we've ever found. However, food for type 2 diabetics is way more important than insulin.
Yeah.
And way more powerful. And so teaching people that in terms of public health and in terms of population health, teaching people how to eat safely is way more effective treatment and prevention than any medicine we can give them.
Yeah, even in the day where you have like the Ozempics and the whatnots, they those are powerful and amazing and kind of wonder drugs in their own right, but they still don't. There's another stopgap, a good stopgap in some cases life-saving stopgap, but they're not the same as fundamentally looking at our food supply system and making decisions based on the best possible health outcomes. Instead, we're looking at other factors first: cost, agricultural leadership, and markets, and political moves, and all of that. That drives me crazy, because as someone who gets right up to the edge, pre-diabetic a couple of times, and I'm very happy to be on the good side of that door right now, but it's hard. You can't go anywhere, including grocery stores, without being bombarded with stuff that there's no way it's going to help me.
Yeah.
You know? And I'm not trying to blame society for this. It does come down to one's personal choice making. 100% it does. But try putting, I don't know, that's like telling a drug addict to stand in a room and all along the walls are shelves of free drugs of his choice. Heroin for miles. Don't touch any of it. It's up to you. It's all about you and your self-control, but I know you can do it. But that's a room we have, and we're going to go ahead and make that where you live. Like, that's kind of what this feels like sometimes.
Well, and think about it this way. You don't have to have crack to survive, but you do have to have food. So add another layer of complexity, even more so on top of that, right? So the analogy that I use for patients all the time, the problem with food these days is that our science for creating new things has far outstripped our body's ability to deal with them. And so if you remember back the Jetsons and the Flintstones, remember Fred Flintstone would eat a rack of ribs that was the size of his head, the size of a car?
Oh, yeah,
right?
baby. When I was a kid, I thought that looked good.
And George Jetson would eat a pill for dinner.
Yeah, he would.
Right? So we have gotten to the point where you could eat a pill for dinner.
Sure.
The processing of foods has gotten to a point where we could consume that much and be fine. But our bodies our brains are not built for that. Our culture is not built for that. And so we don't talk about it that way, even though we've gotten there. We have realized the George Jetson future, but we still are not adapted to the George Jetson future. And that's where that's the complexity of saying, is this a prevention system or is it a treatment system? Because we've got treatments that do a lot of things, but we can't fix everything. And so if you were going to ask, are we better at prevention or are we better at treatment? We honestly have more tools to be good at prevention, even though we have 20,000 drugs to work on for treatment.
Yeah.
And that's where it gets kind of tricky. If you start talking about things like cancer, where we have less of a control over some of the modulators there, absolutely, sometimes treatment is going to be better than prevention.
Right. Because in that case, you've got some serious bad luck business going on too, right?
Exactly.
And hereditary factors.
Mm-hmm. Well, and diabetes, type 2 diabetes has hereditary factors. To borrow an analogy, and I don't want to get too graphic here, but the saying in medicine a lot of times is your heredity loads the gun and your behavior pulls the trigger. And that's where we've got to be really, really careful.
I like
that we know which parts are more important. And that takes a lot of complexity and understanding that sometimes people don't want to take the time for.
Yeah, it's wild. I had cataract surgeries when I was 41, 42, which is very young for cataracts. And I had a number of doctors, eye doctors included, that were like, I've never seen anyone this young with cataracts. So they all thought, oh, it's this weird thing. Well, I finally talked to one that said, no, this is hereditary. It's rare, but probably someone in your family have it. Sure enough, my dad had cataracts at like 38 and didn't get him taken care of till like his mid-40s or something like that. And it hit me. I had 2 surgeries about 3 weeks apart that I was fully awake for that took 8 minutes each. And my doctor listened to Stairway to Heaven during one of them. And I don't remember the song on the other one, but they were fixed, done, and my eyes are better than they've ever been in my entire life, including when I was a kid, because now I have these great monofocal, lenses that actually corrected a lot of vision problems that I was having that have nothing to do with the cataracts. But I still was just hit then, and I still feel this now. 100 years ago, I got wide eyes and I'm on a porch telling stories, or I'm dead, or like I'm literally a blind man. And 100 years later, it's an 8-minute surgery and everything's good. That kind of progress is no joke. It's like a serious jump ahead in something that used to be, well, that's the way those dice are rolled. And even in my dad's case, they had less options. And 10 years before him, you'd had to put your head between 2 sandbags and not move for 7 days. And you weren't even getting replacement lenses. You were just putting giant glasses on for the rest of your life, looking like Bubbles from from the Trailer Park Boys.
Trailer Park Boys.
Yeah. So it's easy to get all bunged up, I think, sometimes in, as if this wasn't such a profited business, we would be, but also there's some serious innovations being made. And I realize a lot of these innovations are happening all around the world. It's not like, I don't want this show to become, we're just coming from a U.S. centric point of view. But we also have so many dichotomies here of a great scientifically based healthcare system, one that is practicing. I don't mean like people on the top trying to make new ideas happen or whatever. But what's working is working and it's all good and powerful and all that. But at the same time, we have confusion and we have non-coverage and we have all these other issues. So I'm just trying to paint that to be a different color than it is. But it does feel like the system as currently constituted does a lot of confusing and honestly burning people out, making them go, I don't know what I guess I'm just not going to go. It'll be fine. I'll go to the next appointment. Like a lot of that thinking. And is there a tipping point for that where you're like, oh crap, we did that too much. And now, we've seen a rise in about 15 different preventable things because the person never went in.
It's the law of unintended consequences, and it happens all the time. Yeah. It's part of what we were talking about with insurance coverage. It's part of what we were talking about with limiting resident hours. All of those things come up to this idea of what are the things that will cause that J-shaped curve to occur. So there's a certain point where you get the apex, and then if you go too far, then you start going back down the other side.
Right.
And yeah, there are lots of things that happen that way. There are medicines that we give that are great if you give them for 3 years. But after that point, they actually turn the other direction and they can become more detrimental if we're not being careful and monitoring what's happening.
Yeah.
And there are lots of people that are getting access to care that didn't have it before. And now, unfortunately, some are losing access that had it. But in the grand scheme of things, it's all those systems that are put in place that are causing a lot of these issues with, burnout or exhaustion or however you want to think about it, that idea of I don't want to think about it. And that's hard because it is at a system level that we have to make those changes. We have to start teaching people about how to take care of themselves. We have to start teaching people that there are certain things that do matter a lot, and there are others that we have culturally created this idea that they are so important, but scientifically or medically they are not important at all, or to the point of some of the things that you were asking about.
Yeah.
We don't want to say that everybody needs to have plastic eyeballs.
Yeah.
But the people that need the plastic eyeballs, we better make sure that we got plenty to go around so that we can help those people that need them.
Yeah. Like I feel like I got a miracle treatment for my eyes that I would not want to deny anyone.
Yeah. Like, and how do we create a system that prioritizes making sure that resources are available for the people that need them, while still giving the ability for people that want to pursue other things to be able to take that path, without also leaving behind all of the people that either can't afford it or don't have the time or don't think it's important.
Right.
We want to make sure that we're still talking about things and having conversations and building those personal relationships. And that, when we talk about how the system is built, that has to be part of it. That's why you can't run medicine just as a business. A lot of people have tried to do that for many, many decades now, and it keeps failing. Because when I started working with my dad, one of the things we focused on was, when you come to the doctor, do you say, I go see Dr. Tolbert, or do you say, I go to the Intermountain Health System?
Oh, right.
Right? Do you have a relationship with the Intermountain Health System, or do you have a relationship with, Dr. Tolbert at that point?
I have a doctor. So we actually literally have IHC here, Intermountain Healthcare, and I have no relationship with them other than that's where I'm getting billed. That's who I'm fighting if something's wrong. That's where mistakes are happening. But it's really me and my doctor. Exactly. With the relationship. So that's interesting that you say that, because I hadn't really... The problem is, I've felt this before when I go to a doctor and I feel like the relationship is being severed by the insurance. The insurance company's getting in the way. It's like the guy at the party going, hey guys, what's going on? Are you guys going to pay me to be here? Like it just feels like it's like bugging, it's wrecking the relationship a little bit. And that's exhausting. It's frustrating.
They can, but it can absolutely be frustrating. But it's also the side that they're the guys that are coming in and throwing $1,000 on the table and saying, here, take care of this person for me so that they don't have all these problems.
Fair point.
So they are the villains and the heroes at the same time. And that's the way that our healthcare system in the United States is built. It is built on those premises. And that's the hard part, because how do you vilify somebody who is doing all that good without also talking about the good that they're doing?
Yeah. Or... it's so easy to like you mentioned, you poked at it earlier, but like you look at some of the CEOs' salaries and you go, are you freaking kidding me? And then you hear about a nice old lady whose cancer treatment was denied by the same firm, and you go, are you freaking kidding me? And it's easy to then just say, well, that's just a dirty blanket from tip to tip. I don't know. I made that entire, I don't know what that means, dirty blanket, but no one likes a dirty blanket, right? Nobody likes that. Right. So that's fair. But
that's how it's a good way to get a disease.
Exactly. Yeah. Nobody wants dirty blankets, but it is easy to just lump that all in like that, and then lose track of the complexity that we're in. And I understand that it would be great if we could just drop everything. Like everyone just wants to reset and start over. Sure, in theory, but at scale, it's like you're talking about a massive, unheard of, probably never going to happen kind of thing. It doesn't happen in history. Name another time where this sort of thing happens overnight. It doesn't. So we gotta sit in our poo sometimes,
Decades worth of system building absolutely need to occur. However, I will caveat that by saying there are times when things have happened overnight or in a much smaller time frame. And we had an opportunity to do that about 5 years ago or so, but we kind of squandered our opportunity, and that's a whole other set of discussions.
Yeah.
But we had a reset on the table, and we didn't take it. So there are times like that. World War I, World War II. Those are the big things those are the times where things pop up that were not available before or that didn't occur before. That's where we got private insurance, was right after World War II. We had a lot of people entering the workforce, and there were caps on how much money people could pay to have somebody come in as an employee.
Right.
So benefits became a thing. Before that point, the insurance was exactly what you talked about, throwing pineapple into the hole.
Yeah.
But after that point, now it's your employer is now paying for 3/4 of that because they can't give you an extra salary, but they'll give you some perks to make sure that you want to come work for them.
Yeah.
So that whole system is built on a 70, 80, 90-year-old system, and we still use it today. And there are problems there that we've just kept putting Band-Aids on over and over and over again. And so now we have this big stack of Band-Aids. Instead of peeling one off and putting a new one on, we just put one over top of the next one.
Yeah. It sucks that the two examples you used were there had to be a war,
Yeah. Or a pandemic.
Or a pandemic. Yeah. And that was my next question, and probably our last for today, as we look forward to episodes that are a little more focused on specific issues that people might be dealing with, their personal health, that sort of thing. We're also going to give you guys very shortly here a way for you to give us feedback that we can directly respond to on the show. But I had this question. I hear this all the time. I still hear about it, about how healthcare providers, doctors, nurses, really the gamut of hospital staff, were so burned out after the pandemic. It was such a brunt force trauma to the system. That it just about not fell apart, but really strained its limits. Has that changed since? And are we better prepared now for the next time that sort of thing happens? Or do you feel like we got a little thin Band-Aid on top of that? Like, what are we doing?
It's a little of column A, a little of column B, to be honest. We are better prepared in that we understand the level of complexity that goes into taking care of things like a pandemic.
Yeah.
We are less well prepared in that there are not the right systems that evolved out of what happened. We did a lot of field medicine, which anyone who has ever been in part of the medical field will know that means that you kind of put together the things that you can. You MacGyver it together, for lack of a better word.
Sure. Mad Max it, I like to say.
Exactly. But that doesn't stick. That is what you do when that's all you have.
Right.
And so it's about learning how to build better systems. And there are people working on those things. Don't get me wrong. It's not that it isn't on the horizon, but it is not a priority right now, and that makes it a little more difficult to get to that place. However, as far as burnout, it absolutely made an impact, and not in a good way. We had roughly, I don't want to misquote this, but the last statistic I'm pretty sure I read was there were at least 12,000 doctors that left the medical field because of the pandemic. That's what they cited as their reason.
Wow. That's a lot.
Now, a lot of times that's going to be people that were ready to retire or were waiting to retire and just decided to do it at that point.
Yeah.
But there are also people that just left because they didn't want to do it anymore.
Yeah.
And that is a massive loss that we are still feeling. We are still way behind from across the board for all of the different healthcare professionals that we're talking about.
Yeah, nursing and stuff, all that got affected, right?
Everybody.
They took off, changed their minds. I could do something else. This is not worth it. All that, those sorts of things.
Pharmacists, pharmacy techs, nurses, people that work drawing your blood, the phlebotomists at the Quest lab and the LabCorp lab and any of the other labs. We had such a hard time. In the last 2 years even, we've had such a hard time with not being able to get people in to get blood drawn just because there aren't enough lab personnel.
Yeah, I've got a radiologist, I think is what he is, friend in not Sweden, sorry, Italy, who says same problem. This is not a U.S. only problem. It's not only we were not the ones stretched so thin. Everybody, this world was stretched thin medically, and he says same deal. They're having a hard time getting back to their normal hired levels. And also he said the hardest thing for them were at the hospital he's at is some of the best people in their field are bailed or died. Like Italy got, I don't know if anyone remembers this, but Italy got hammered early in the pandemic. It was very bad. And I don't know, we just forget so easy. And then 5 years passes and then we're like, are we doing anything about it? And, that's one of the things we'll dig into as we do a series of these is figure that out. Because it's a race against an unknown a little bit. If this does happen again or happens in a more severe way or, bird flu makes a proper jump to humans or whatever, and we're not prepared, will we ever be truly prepared? It's hard to say. But I just feel like from the outside looking in, it feels like we're not. And so you're going to help me both understand how prepared we are and also maybe put some realistic expectations on what we could expect, because I don't want to do that again. That was awful.
Yeah, me either.
I mean, it feels like the most obvious thing to say. Hey, it'd be great if we didn't have another pandemic. It would be great.
Yep. No more pandemics. We're putting that out there. We don't want any more. Thank you.
Except for that first week. Not to diminish the destruction and death, all right? I'm in this very privileged position I was in, but I kind of liked that first week at home just watching streaming stuff and chilling. I kind of liked it.
during that week, I was spinning up a video visit process for an entire hospital system, teaching 1,600 physicians how to do video visits because I was the guy that had a studio in my basement because I've been doing
understand this stuff, right? Yeah,
exactly. So I'm the tech guy. I'm also the doctor. So I crossed that bridge. That was my last job. So
that's a very good. That's a very good perspective for me to have on a week where I was like, oh man, this is all right. The pollution's better. No one's driving. Yeah. I can just chill on this
Traffic
couch.
was beautiful.
Oh, it was amazing. I'll bet. Well, I don't know. I don't know if we have stats about that, but I have to think.
We do. There were fewer car accidents. There were fewer. Yeah. There was so much less stuff going on when, like you said, pollution was better. Yeah. Electricity usage was actually somewhat better, but gasoline and fossil fuel usage was way down.
Way down, yeah. Yeah, it's too bad we couldn't maintain some of that.
Yeah, again, we had an opportunity and we didn't take it, and we can talk about that all we want, but the idea here is we want to make sure that everybody's got the tools in their toolbox to be able to deal with that kind of stuff if it does happen again, but also just day to day. Things have changed. We live in a post-pandemic, well, not even truly post-pandemic, but post that first couple of years of the pandemic world, and we have to be ready to talk about what that means and to talk about what healthcare in this new era is going to entail. There is, again, scarcity in medicine, and that was something we weren't dealing with as much.
No, if anything, it was maybe a little, I don't know, I don't want to say an excess, but, there was plenty of doctors, plenty of nurses, plenty of things, plenty of resources, and now people are just kind of like, eh. One of these days I got to ask you what you think of The Pit, because I thought The Pit kind of nailed it. Like that feeling of like, oh man, because the pandemic plays a big part in that show, and that one rocked me. I loved it. We'll talk about that more later, though.
We can do a whole episode on all of those shows and which ones really mimic reality and which ones are totally off the wall.
Well, the worst one's got to be that new one with Don Johnson, that freaking cruise ship thing. Terrible.
Grey's Anatomy. Grey's Anatomy will always be the worst.
Really?
They had in one episode they had a pediatric neurosurgeon doing GI surgery within like 20 minutes of each other. They were doing brain surgery on a pediatric patient and then adult gastroenterology or GI surgery.
Wow.
And it was in one episode. So nothing ever beats that for being bad.
And that wasn't even the one where what's her name saw a ghost of her boyfriend.
Right.
And
that leave out all of the horrible sci-fi episode or fantasy episode parts of it. The medicine and the science behind it were all sci-fi too. There is nothing about that show that is accurate in any way, shape, or form except the color of the scrub.
You heard it here first, everybody. Finally, we have a final answer on all things that terrible show. Well, anyway, here's the deal. We want you guys to participate. All right, so that means you can text us, you can voicemail us. You can get with us any way you want. So I'm going to give you a couple ways to do that. Go to voicecast.app/medical. I've already got a few people using it. They just found it. But if you go to voicecast.app/medical, you can leave a voicemail there or a text there. Either's okay, and we're happy to read those on the show, play them on the show, especially if it's something relevant to these kinds of topics. So, keep that in mind as you're doing those, and we would love to hear from you. So please use it as frequently as you can. Write it down, voicecast.app/medical. You can use a computer, a phone. It doesn't matter where you do it. Dr. Tolbert uses these sometimes to contact us, so he knows all about it. If he can do it, well, then you can too. I don't know what that means. Of course you can do it. Don't forget our website. It is themedical.show. Yeah, that's right. Themedical.show. We got a .show domain, yo. So go use it, themedical.show. You can also find us on Blue Sky, Dr. Tolbert, that's drtolbert.bluesky.social, and I'm over at scottjohnson.zip. Just search for our names, you'll find us. And on Discord, you can leave all your comments and your thoughts there as well, frogpants.com/Discord. It is doesn't take anything to get in, and once you do, you will find the Medical Show sub-Discord channel in there, and you can hang out with people, talk, tell us your feelings, thoughts, and ask your questions. Jerry's already been in there asking a bunch of them, or answering a bunch of them, which is pretty awesome. Thanks for this first episode, man. It was awesome. Had a great time.
Yeah. I had a blast.
Can't wait to do more, and there will be more. So come back again for the next episode of The Medical Show. We'll see you then.
Once upon a time, there was a hero named you. Find the next step of your quest at frogpants.com.